The topic that has been allotted to me is on redefining type 2 diabetes care through weight reduction. I am also from Eli Lilly company sponsored speaker. That I need to inform you all. I am going to receive honorarium. Thank you, Lilly, Eli Lilly. Okay, I think Dr. Sriram Mahadevan had nicely put how things are happening in people with the diabetes. The obesity is the culprit, and that is the one which is responsible for increasing the problems of type 2 diabetes, hypertension, dyslipidemia, whatever you call. And finally, early treatment in people with the diabetes will pave the way for these individuals to get rid of problems in cardiovascular morbidity as well as mortality. Now, addressing the excessive weight as early as possible could provide more clinical benefit than focusing exclusively on glycemic control. So, move away from the control of diabetes, try to concentrate on obesity. That is going to give you much more beneficial effects for your patients. So, you know very well that excess weight or the obesity is responsible for type 2 diabetes development, hypertension, dyslipidemia, coronary artery disease, and then obstructive sleep apnea, MASH, and osteoarthritis, all those problems. And of course, diabetes is responsible for micro as well as macrovascular complications, which you need to prevent as early as possible. The one thing that appears on the left side is about the weight control upstream intervention. In people with overweight and obesity, the modest and sustained weight loss improves the glycemic control, blood pressure, and lipids. On to the right side, you can just see the achieving the HbA1c targets of less than 7% has been shown to reduce the microvascular complications in type 2 diabetes. I need not emphasize on this important point that we need to keep the HbA1c levels at least less than 7 in older patients. In people with existing cardiovascular disease, less than 7. Young patients, probably you should bring it down to levels of 6.6 or 6.7. That should be the approach. And if you are going to start giving advice for your patients to reduce the weight and reduce the obesity problems, I think it gets reflected in the form of a remission of diabetes, not the reversal of diabetes, that you need to keep in mind. In addition, I need to tell you that people with obesity, with or without metabolic syndrome, are prone to get the development of diabetes, and that can probably be prevented. Pre-diabetes can also be prevented if you are able to bring down the weight sufficiently to the goal, what you want, at least by therapeutic lifestyle changes. Most of them probably will not adhere to the lifelong advice of a therapeutic lifestyle change, which will not change this attitude. You need to probably depend on the pharmacotherapy. Obesity is probably responsible to create a lot of problems, not only in adipose tissue, liver, pancreas, and how things are happening for the development of type 2 diabetes. I need not give you the details how things are happening here. Suffice to say that the pancreas is that's the one that is getting involved. The liver is again another culprit, and the adipose tissue is the one that is responsible for increasing the problems of lower adiponectin levels. And then mechanisms linking the weight loss and the diabetes management, how weight loss helps to manage type 2 diabetes. In fact, no, if you reduce the weight, probably it can create an improved insulin sensitivity, decrease the inflammation, increase the beta cell function, and increase the gut microbiota. Probably these are all very important issues which need to be addressed by all of us when you talk about the weight loss in those people with type 2 diabetes. Strong clinical evidence supports the obesity management as a core pillar based on all these three trials or the studies which had been conducted, probably very well drafted studies which gives you information about the evidence to support the obesity management. The first study says about 1 kilogram reduction of your body weight is associated with a 0.1% decrease in HbA1c. That's number one. Number two study is at 12 months, at the 1 year period, intensive weight loss lead to diabetes remission nearly to 46%. Diabetes remission nearly to 46%. That's amazing. That point has to be kept in mind. Not only within you, you need to probably give the information to your patients who are seeking advice, and the relatives, obviously they will also be obese. You need to tell them that how they can probably reverse this 46% participants when compared to the usual care of only 4%. The other study is designed as a randomized controlled trial. So 1 kilogram reduction in the weight probably gets reflected in the form of reduction of 16% type 2 diabetes adjusted for all other risk factors or variables. In fact, according to the academic bodies like ADA or EASD, we have some clear information. Type 2 diabetes is a high magnitude of weight loss leads to better outcomes. Number one, 5 to 10% of weight loss leads to metabolic improvement. If you go beyond that, up to 15% or more, you may have a disease-modifying effect and lead to remission. People with type 2 diabetes especially benefit from early, aggressive treatment. Damage caused by the type 2 diabetes presents early compared to the ongoing or lifelong benefits of early, aggressive treatment. This is very important slide which I thought I should project before you so that you will remember how much of benefit that you are going to get by advising your patients to reduce the weight. If somebody is reaching 5% weight reduction, you can anticipate some improvement in hypertension, in improvement in hyperglycemia. Whereas 5 to 10%, you get improvement in urinary symptoms, the PCOS also, the dyslipidemia gets altered in the form of reduction of triglycerides, improvements in HDL cholesterol, though not much improvement in LDL cholesterol. Asthma and airway disease also comes down when the reduction in the weight is appreciated by your patient. MASLD progression also probably gets improved. And then the 10 to 15% weight reduction, it improves the problems of MASH as well as OSA, GRD, and the knee OA problems. If you reach more than 15% weight loss, I am sure you will get the maximum benefit of reduction of cardiovascular risk to the extent of nearly about 10% or 12%. Various studies have shown various figures. And then the CV mortality also comes down. And then the repeated hospitalization for heart failure with the preserved ejection fraction, including the coronary mortality due to heart failure, can also be brought down comfortably if you are going to reduce the weight in your patient who has all these underlying problems. The significant reduction of the HbA1c had been seen in this particular study, which has shown that is about 1.2%. The last one you can just see. Taking into consideration the index date and then the 1-year follow-up data from the US large study, more than 1 million people were analyzed for this study. Real-world data has been projected here, which gives you an indication that if you are able to follow up these patients, you can appreciate that there's got about 1.2% reduction in the HbA1c that is seen in this particular study. The same study, which had shown that if you have a follow-up of nearly 5 years or so, you do get a maximum benefit of the HbA1c also, and nearly about 64% of the people achieved HbA1c less than 7% even for 5 years follow-up. That again gives you an encouraging information from the real-world data published in the United States. That gives you important information that reduction of weight improves the diabetes control, brings down the HbA1c in the long run, not only in first year, but also in the subsequently for a follow-up of 5 years. If you reduce the weight by about 5 to 10%, it can reduce the cardiovascular disease risk in people with diabetes. 10% reduction and more can reduce the diabetes-related mortality risk. Up to 25% you can get the higher probability of diabetes remission. And of course, the HbA1c reduction is also appreciated. Now I'm going to project some hypothetical case study. 55-year-old female with type 2 diabetes and obesity, age 55 years, female, 84.5 kilograms of weight, blood pressure 140/90, BMI is 35.7, waist circumference about 115 centimeters. You know, waist circumference is much more important than only calculating the body mass index. Body mass, I'm not neglecting it. You need to do that. But at the same time, at least from tomorrow onwards, see that you keep a measuring tape on your table so that every patient who walks into the clinic, whether he is a lean fellow or an obese fellow, try to see the measurement in the waist. That's most important. More than 90 centimeters should alert you. More than 80 centimeters in a female should alert you that the patient has got a problem of so-called abdominal adiposity, which paves the way for these individuals to get into complications of adiposopathy. So this comorbidities in these patients, type 2 diabetes and hypertension, HbA1c 7.6 high, the kidney function normal, LFT almost slight increase in the OTPT, total cholesterol 112 good, LDL 80 almost okay, HDL cholesterol 31, and the triglyceride 143. Patient actually received oral semaglutide, aspirin, rosuvastatin, as well as the telmisartan. The therapeutic targets in this patient should be, the glycemic control should be properly maintained. It should be less than 6.5. Weight reduction is about 10 to 15%. Only then she will get rid of all these complications related not only to obesity but also to diabetes. Blood pressure target should be less than 130/80. That's a controversial area. I will always say the diabetic people can be allowed to bring down the systolic blood pressure less than 120. The studies are there now. The lipid optimization less than 74 overall. If the patient has already developed a heart attack or a stroke event complicating diabetes, you need to bring it down to the less than 50 milligrams of LDL cholesterol. What about you need to convince the patient, counsel the patient properly. That's most important for you to have a long-term adherence with respect to any pharmacotherapy or even for lifestyle changes. Explain the mechanism of the newer drug, tirzepatide, and then advise to follow the protein-rich diet and the regular aerobic and strength training. Potential side effects need to be explained to the patient. I always tell my patient, you will get nausea, you will get some vomiting on and off. You may not have an inclination to eat. If they keep 3 idlis on the table, probably you will try to take only 1 idli. You will not have an inclination to eat more and more. So you will have this problem for the first few days. Later in the next 4 injections, if you are able to tolerate this, probably in the next cycle when you are increasing the dose of this injection, you may not experience it. Of course, it is true. I've been seeing patients. They are only having burping all the time. But otherwise, they get bloated sensation. Otherwise, nothing. I think it's very safe now. I think we need to be very happy to live in this millennium where you have popular drugs. One of the most popular drugs is a statin. Look at the SGLT2 inhibitors. Look at the newer drugs which are now coming, GLP-1 receptor agonists and GIP-1 receptor agonistic drugs. I think we should be very, very happy to live in this millennium, not only to treat our own relatives, but also our own patients and their relatives for a healthy living, to have them or give them a long, long life. So this patient was started with a 2.5, later jumped to 5, 7.5, 10 milligram in a matter of 6 months. But you can just see the weight has come down from 84 to 74, and then the HbA1c levels of 7.6 touched 5.8. These are all the parameters which she was having it in the beginning. 84 came down to 74, 35 came down to 27, the HbA1c came down to 5.8. Surprising, amazing to see a tight control of blood sugar. 140/90 of blood pressure touched 130. 90 is still high. Most of them probably try to neglect the diastolic blood pressure. It is always and or. 120/80, after that 120 to 139, 80 to 89, and or. You are forgetting that and or. You are only trying to talk about only that 80. No, try to concentrate even on the diastolic blood pressure. 115 waist circumference touched 85 centimeters. She is probably going to touch 80 centimeters or so, provided she continues to take the drugs. Ladies and gentlemen, these are the takeaway messages of my talk. Obesity, especially abdominal adiposity, is highly prevalent in type 2 diabetes and is a key driver and the comorbidity of the disease. Targeting weight alongside the glycemic control addresses the root cause of the type 2 diabetes, breaking obesity, diabetes cycle, and delivering sustained clinical benefits. Sustained weight reduction improves the glycemic control, lowers the diabetes risk, may induce remission, establishing the obesity management as a core pillar of type 2 diabetes care. In a real-world practice, tirzepatide delivers clinically meaningful improvements in body weight, body mass index, glycemic control, supporting a holistic approach to type 2 diabetes with obesity. A patient with a type 2 diabetes and obesity had been projected. You had seen the reports what she has been now getting after a period of 6 months of therapy. Thank you very much, ladies and gentlemen, for patient listening.